lot of you in the room have already heard me talk on I'm Dr. Brouillard. I'm actually 57. I had my stroke, I didn't think about it, when I was 51. I think a lot of what I'm going to state today is very much similar to Steve. What's always amazed me, and this is sharing something with somebody, a stroke survivor like myself, as I go to stroke survivor meetings every month, and it's amazing for all the different strokes we have, how much we have in common. I'm always amazed. It's I say a brain, and I also feel I have a lot in common with people with brain injury when I meet them. I share a lot of the same things that are more common than different, and the brain is very different. So this is the actual title of the Stroke Survivor Adapting, Learning, and Thriving is not my title. It's, I was doing a talk and somebody said I used to just put Stroke Survivor, and they said after the talk you should change it. You should put the other thing to define yourself. And it is a personal account of my journey. I like this, and mine is a bit different because as a physician, I always take the story. About 2 weeks, I think it's about 3 weeks before I had my stroke, I was actually I did a talk in Belleville to family doctors, telling them what they need to, why they need to be more careful with their patients to reduce their stroke risk. It was a good talk. It obviously was well received. I remember because I got the evaluation for it. There's only one problem. I wasn't listening to the talk. The one thing I always mention, you cannot listen to yourself. I think it's impossible to be your own lawyer. It's what you can be, and it's impossible to be your own physician. And I think that was very telling to me when I thought about this over the years. The Stroke Storm Watch, I think, is a great thing. It's actually a Native American tribe in the United States that trying to put together a stroke program to warn people. And I just like the idea that it's more common language. It's one of the things I've learned after I've had my stroke and going back to working, but talking to people during the time I've had my stroke. Is why are we complicated in medical language? People talk simple language and they hear simple language. So April 25th, 2007, that was the infamous day, and I went to work that morning, and I noticed the night before, 2 o'clock, I'd been up, and my son says, "Why are you up?" Because I usually don't get up at 2 o'clock in the morning sitting on the couch, and I said, "I have no idea. I just didn't feel good tonight." And he says, "What's wrong?" I said, "I have no idea." Went back to bed about an hour later. Got up the next morning, I said to myself, "God, I knew that me of mine was starting to give me some problem, and now I thought my leg was stiff." But I got to work. And what was I doing at work when well, again, you never really listen to yourself. And I'm actually admonishing this patient that he has a AAA and he's abdominal aortic aneurysm, and I want him to get his blood pressure under control and reduce his salt intake. And I'm telling him all this, and as I'm telling this, I'm starting to realize, words are getting a little funny. I'm having a hard time articulating them. Not today, at the time. I still have time. So I said to him, I said, "Well, we're going to get a repeat CT for your abdominal aneurysm, but here I want you to start this new medication." I come to write the prescription, and I realized, I can't write this. I'm going to print. I'm printing the prescription now. There's only one problem. I have to sign my signature. I managed to scribble some signature. And so by the way, I write very neatly my prescription, so they're not neatly, but I'm saying to myself, this is terrible, but the pharmacist not even think I did it. I got up to the front. I told the nurse, which was unusual, I said, "Can you fill out the CT requisition for a CAT scan?" I went back and I told the other nurse, I says, "I'm having a stroke." And she says, "What?" I said, "I'm having a stroke." She says, "Yeah, I don't believe it." And then she looked at me and she says, "Side of your face just dropped." She said, "You're having a stroke." Went to the hospital. Obviously, I had been probably having a stroke for the last 10 hours by the time I got to the hospital. Having said this, my idea was, I'm going to get this is exactly what I told my secretary. I said, "I'll be back on Monday. Don't worry about it. I'll be back." And I called my wife before I went to, as we were heading to the hospital and stuff, and I told my wife, I'm going to the hospital, but don't worry, I'll probably be home tonight. And at this time, and she didn't even, she tells me, she didn't even know what the hell I said on the phone. But I don't even know the comprehension. So what's the problem that I have that I don't listen? At that time, my blood pressure is being elevated. I'm already on medication, but I knew in the last 6 months that I hadn't been under control. I have no clue that I have diabetes. That's just all found out the day of my stroke. I obviously know I was overweight. I had ballooned up, I think, about 280 pounds the year before. I decided to lose some weight. So I was told I had, my cholesterol was elevated. And unfortunately, this was sort of the profile when I got to the hospital. Blood pressure 230, 124. They're thinking I might have had a bleed. No, I didn't. I have hemiplegia, I'm dysphagic, I'm dysarthric, I have the polio. Things are not looking good. They don't look any better, and fortunately the emergency physician on that day is somebody that I'd been there when I was a medical student, so he says to me, he says, Dan, when do you have your other strokes? I said, so no, this is not really not sounding good at all. I already had a few more strokes. And you know, in retrospect, I'm always asked, was always asked, you know, did I ever see the stroke coming? Was I aware of it? And in a way, I think about the year before. I think I did. And one of the things is I didn't know it at the time. But one of the things that happened to me, I had become very emotionally labile. And not in a rage type of way. I started not being able to watch any television program or movie that had any potential for sadness. And to this day I can't. I mean, the other day I'm watching, where my wife's watching television, I look at it, she says, oh, that's a silly show. And she looks at me and there's tears in my eyes, but it's sad. It's sad, it's silly. And it was sad. It was sad to me. So I've had this emotional thing for about a year before. The other thing I had started doing, and I have no idea where this came from, I also had this thing that for a year before the stroke, I had this obsession that I wanted to record 100 songs. And I'm not musically inclined, and I kept thinking I want 100 songs. And my wife finally told me, you want the 100 songs? Because I wanted to help me make the list. And says, make your own list and record your own song. And for some reason, that was repetitive strength. So here I am now. I'm at, and the one thing, maybe I should preface all this by saying, you know what we're talking about today, about access, and hopefully by the end of my talk, you'll see, I just thought, all the stroke care I've had, I just thought it was everybody got it. And so it's not, so one of the things I've had, I've been very fortunate as you go through this. So first of all, I was an acute stroke unit at here. I got transferred to St. Mary very quickly. I mean, everything was very good for me. Words of wisdom for me were similar to what Steve was saying in a way. It's saying, you better concentrate on now and you better concentrate on yourself. Because what do you think my concern was at 51? My wife, my son, my private practice, all my patients. What's going to happen to them? And that was a very, I had to block that out. I really did block it out. And for me, the biggest thing I've had in my stroke, and now, so you're very kind and always worrying, it's almost, she's always worried I'm going to fall. And they still have to this day a fear of falling. I don't let it, I don't realize that. I don't want you to think about this because every time you think I'm going to fall. But I have this fear of falling. I've only fallen once since my stroke. But to me, falling is an incredible fear I have. It comes from being a kid, and I just exaggerated. One of the things is, and I'm sure Steve would agree with this, one of the things I've shared with almost every person that's a stroke, and you know, when we talk about intensive rehab and things like that, I totally agree, you have to have more rehab. But weakness and fatigue is very underrated in patients with strokes. And to me, I could not believe how tired I am after I've done any activity. I think that was my most limiting factor, and still is to this day. I get to the point where after I've done certain things, it's almost my body and my brain has to shut down and I have to rest. And if I don't do that, I don't function. And I've been in a few situations where it's almost any gains that I've made in my stroke, I could really think they never occurred if I get to that level of fatigue. I go, oh my goodness, I just lost everything. And fatigue is a very prominent thing. And the other thing for me has been very, I'm talking to people that know all this, but for me, this idea of compensation versus restoration has been a pivotal thing the way I've looked at my stroke. And one of the things that's been amazing to me, and it's something that as a physician, and you got to realize, when Steve was talking about, when we used to have we used to knit stroke patients, go to Hotel Dieu and KGH, I used to knit them at Hotel Dieu. My idea was, back in the 80s, and what happens in 2000 now with stroke, it's so vastly different. It's just an amazing thing. But compensation versus restoration for me, because one thing is, I don't know, this is what similar to Steve, I don't know when the recovery stops. And the plasticity, when we talk about fast stream, slow stream, I think there's fast stream, there's no doubt, but I think slow stream rehab I've been on that road for the last 6 years and I'm still on that road. And I hope it never stops. I've said for me, in the last few months, I've regained my hitchhiking time. And I go, look, they're not planning to hitchhike anytime soon, but it is a convenience. And this is sort of my journey pictorial by the time I got home. And I do want to, because I want to share what Steve said, and I think it's a very important thing as we're planning for this, is that there is the cocoon feeling I had at St. Mary's and at KGH is incredible. I did want to go home. But I have to admit, I think patients when they're in hospitals, and we look at hospitals and we look at them, we want to get the patients out. And you know what? I've always looked at it this way, the patient's better off at home. But there is a comfort feeling about it, and don't ever, to me, being at St. Mary's was not uncomfortable. I could see myself still being at St. Mary's. This is a funny thing to say in a way in the head was. It's a comfort thing, it's a security blanket. And when I finally got home, I remember the first time when Mary Jo had delayed my going home for a weekend, and I was so upset at myself in a way. I said, geez, I'm not well enough yet. And I finally went home for a weekend passed. And you know what I did when I went to the front door? Similar to what Steve did. Oh, what the hell do I do now? I'm not too sure why am I here? I can't walk really at that time. I can't do anything. And why am I not home? I wanted to go back to the hospital. That weekend, by the time it wasn't, I don't want to be back in the hospital. So I'm just letting you know, part of this is hospitals are very secured patients, but it's not only at that level. This is me now, and I make no distinction when I talk as a physician or as somebody that's required care. I think that's part of why patients, when we're going to talk about patients and decreasing the utilization of the emergency system, discharging home quicker, we're going to have a very good communication with the individuals that we're doing that. When Dr. Bailey's talking about having a frank talk to people within a few days of a stroke, we have to have a frank talk, but we have to also have a frank talk to make people feel that there's something in the community that's just as secure that they have in the hospital. Patients come to the emergency, patients come to the hospital because they feel secure they're going to get attended to. If there's nothing alternative out there for them, they'll be back. You can look at that in people that have migraine headaches. They have bad migraines. They go to the emergency because they'll be taken care of. And to me, I try to highlight certain things about stroke that to me are vital. I said I've had sadness. I was very concerned during my stroke with the sadness that I've already been treated once in my life for major depression. I've always been concerned about this. And the reason I mention it is not because I had a major depression during my stroke, but I think it's critical to identify it. Because I sort of excused myself a little bit, but before I decided I could go back to work, I had a personal friend that had also had a stroke, but he also was a patient. But I was seeing him as a personal friend, and unfortunately he committed suicide. And, you know, when I think about it, I never asked. I never asked him. I actually thought his disappointment was because he had a lesser stroke than me, in terms of function. But I was recovering more than him. And he was very upset about this in a way. He'd always mentioned to me. And unfortunately, I never asked him, how are you feeling? What's your mood? So I'm just letting you know, if you're working with patients with stroke, it's a critical aspect to ask. And this is what I call what we just talked about, the safety net. If you're going to have more community care, and you're going to have, the care in the community, and CCAC involved and everything like that, you got to make sure that you're giving the patients a sense of safety. That says to be an equivalent sense of what it is in the hospital. And that's a transformation that we're going to undergo, not only as physicians, it's not, and only healthcare providers. We have to have the community go through that transformation. And as the community goes under that, we have to be communicating with them that knowledge and that basic message. The community, the patients that I see today, really don't understand ALC. It means nothing to them. It means nothing to the person when you're talking to them like that. And I've been there, right? And they don't understand that I'm discharge and things like that. They just understand I'm getting care. And this is another thing, part of that's the safety net. This is the best pictorial I have of myself. It's a cartoon, but it's me. Everything I do, every time I walk, I have to think about that movement. It hasn't changed from the time I said I've become more functional, but it's just that I have more things to think about than I did before. And I think that's part of the issue is that it's great I can do more, but every time I do things, I say, I've never multitasked since I've had my stroke. When I do my practice, I tell patients now, when I do a physical exam, it's a physical exam, and guess what? I used to do the physical exam and do half my history while I was doing the physical exam. No more. I do my physical exam on patients. I think they get a better physical exam, but they get more time to be asked questions. And what benefit, as when I say, what have I had in terms of what's in the community for me? Well, let's start out. The first thing is, I ended up, first of all, there was very good outpatient. When I went home, I came back as an outpatient to St. Mary's. The other thing that happened to me, it's like I'm involved in a study at Queen's University. And it happened to be, I was triaged to the treatment group. I didn't realize I wasn't even a treatment group. They didn't tell you that at the beginning. And the majority members, and I had another special physiotherapy sessions for the next almost several months. And that was benefit. The other thing that was pivotal to me is that the stroke survivor program became, and they just left St. Mary's at the time, and the senior centers allowed us to establish at the senior center. And I think having a stroke survivor program in the community has been, to me, one of the most psychologically beneficial things that I've had as my stroke recovery. The other thing I've been, and to what's happened since 2007, the other thing is, I ended up being part of going to the cardiac rehab program, though I had no cardiac issue. Because they had just, there'd been some studies on stroke, so it was very good that I was able to do that. I'm involved in REVDA, which is the exercise program for people with mobility. And the other thing, I want to thank these two committees. The reason is, I'm a member of these two committees. I know they've never realized it. It's been part of my retraining to be a physician. Being part of committees has allowed me to communicate with people. And I find that it's been very non-threatening, and it's been a very beneficial thing for me. And the other thing I'm thanking them is these two communities I think are terrific. So at the end of the day, I put this picture up in 2007, and what this picture is all the people that are really involved in my stroke care. I used to keep a number, and I stopped counting when I had over it was 303 people that had had a direct interaction with me since my stroke. What you're doing today is trying to figure out how the hell do we connect the dots so these people are interconnected and we know where people are best treated. Does somebody need more recreation? Does somebody need a dietitian? How do you connect the dots? How do people flow better through the system? And we started with the storm. This is me today. It's less of a storm. There's still lots of clouds. That's my story.
Thank you.